Hi, everybody. This is Nathaniel. We are going to begin here in chapter 34. This is all about pediatric emergencies. As we're going through this, here are some tips and techniques that I want you to use to make yourself the most successful in this online learning environment. When it comes to online learning, some of the biggest things that you can do is to create yourself a area that is dedicated to class. Just like when you come to class, that is what you are doing. The area that you're listening to this lecture in should be as free of distraction as possible. Give yourself a dedicated amount of time to sit down and go through this lecture with me. Take notes just like you would in class. If you have questions, make a note of them and send them to me, because I will respond to those questions. One of the downsides of doing this is that I can't answer them in the moment, but I can and will answer them if you bring them to me. So put your phones away, put them on silent, don't look at them. If you're doing this on a computer or a tablet, make sure that this is what you're doing. Don't be playing a game or trying to do something else, browsing Facebook on your phone, whatever the case may be. Make sure that this is your priority right now, because we are going to have quizzes. We are going to have little corresponding quizzes to each section of this chapter. You're going to have a quiz kind of cumulative over a couple of chapters as we go on, just like we would in class at the beginning of the week. And you're still going to have your block exam. So make sure that you're reading these chapters in your book. Make sure that you're going through this lecture with me, because we won't cover every single thing, but we will cover most things. And this and the reading are very important. Make sure you're keeping up with your workbook, and you should be set for success for a block exam when we come back. So without further ado, let's dive in. The study of pediatrics is the medicinal study of patients that are children. So anybody under age 18 is considered a pediatric when it comes to medicine. These patients differ quite dramatically from their adult counterparts. Not only are they anatomically and physically different, but they're emotionally and mentally different as well. The way they process the world around them is different than an adult. Because of that, they have to be treated differently than an adult does when it comes to medical assessment and EMT treatment. They can still get sick just like an adult. They can still get injured just like an adult. But their response to that is dramatically different depending on their age. And so we're going to look through several different age ranges in the pediatric realm and talk about how to assess and treat them. Then we're going to look at specific emergencies that they have and talk about a bunch of those as well. I've broken up this chapter into multiple parts and multiple presentations so that we can do this in a little bit more bite-sized chunks and not just have you sitting here for a couple of hours listening to this lecture. The most important thing to remember about pediatrics is that they're not just small adults. They are very different. Anatomically, they are very different. Mentally and emotionally, they're very different. They can be very difficult to assess because of their fear of us and fear of what we might do to them. But once you learn how to approach them, it should be pretty straightforward to assess a pediatric patient. Now, this is something that takes practice. And unfortunately, we don't get a lot of practice because kids stay pretty healthy for the most part. But once you get comfortable with that, once you get more comfortable dealing with kids, or maybe you already are comfortable dealing with kids and you just have to learn how to do that in a medicinal environment, it can be very rewarding to take care of these young people and make sure that they get the help that they need. One of the first differences that we'll encounter when dealing with pediatrics is the fact that we're not only caring for the patient, but we're also dealing with their family and caregivers that are around. In general, if you have a calm parent or caregiver, you will have a calm patient. That makes our lives a lot easier because the kids can feed off of whatever emotion is around them. They can detect off of you, off of their caregivers, parents, other people around, if something is amiss. And if that's the case, it's going to amp them up. So we have to remain calm. We have to calm the parent. We have to calm the caregiver, whoever is around, as much as possible in order to make assessment the easiest and hopefully not to miss anything. So here are the age ranges that we're going to look at: infants, toddlers, preschool age, school age, and adolescence. And we're going to go through each one of those individually. All throughout these age ranges, there are major physical and emotional changes that are taking place, and we'll talk about some of those. The first that we're going to look at is the infant. The infant is defined as 0 to 1 year, and inside that first month in particular is called the neonatal or the newborn period. Is 0 to 1 month old. 0 to 2 months is our first major category that we're going to look at, though. Upwards of 90% of their time, of their life, from that 0 to 2 month span is spent sleeping. Otherwise, they're going to be eating, and then they're probably going to go right back to sleep again. They're doing a lot of growing. There's a lot going on, and they just spend a lot of that sleeping, resting, getting the energy that they need. Generally, these children cannot tell the difference between parents and strangers, though there are research studies and evidence that shows that even at this age, the infant can tell the difference between mom and somebody else, between a parent and somebody else. Even if they're not causing a big ruckus over that, there are a couple of interesting studies that have gone on showing that even neonates prefer the sound of their mother's voice or their father's voice over that of a stranger. So while they might not scream and cry if you're holding them, they might not be as comfortable with you as somebody else. They do cry at this age. That causes a lot of consternation to their parents, I'm sure, but usually they're consolable. If an infant is non-consolable, if they can't be quelled, if they can't be quieted or soothed, that is a sign we really need to watch out for that, because that can mean that there's a serious illness going on underneath. Because they can't communicate with us. They can't tell us what's going on. From 2 to 6 months, we have a lot of the same things going on that send off red flags. 2 to 6 months, an infant should acknowledge you, at least with their eyes, when something new enters their field of view. So if you walk into a room with a 2 to 6 month old infant, they should at least look at you. If they don't make eye contact, they're crying, they're not consolable, they're very irritable. Those are all signs of a potentially major issue going on with them. And we really have to make sure that we're focusing on that presentation and doing a good assessment and a good history taking. 6 to 12 months is where a child first begins to develop separation anxiety. They're going to want to hang on mom and dad as an infant. If they get handed to someone else, they're probably going to become upset, and they're not going to want that to happen. If mom and dad is not immediately with them, they may begin to cry or otherwise fuss and kick, and that makes them difficult to assess. Our assessment of infants is just like an adult, however. And in fact, these principles, a couple of these principles, don't change at all. Our assessment begins the first time that we lay eyes on the patient, and that's across the room. We can see, are they being held? Are they laying down? Are they crying? Are they breathing? Is it a weak cry? Is it a strong cry? Are they breathing well? Are they breathing quickly? Do they have any cough going on? Do we hear a hoarseness or any raspiness? Do we hear wheezing? Are they using any accessory muscles? Can we see them belly breathing? Do they have nostril flaring, nasal flaring going on that could indicate shortness of breath? How does their skin look? Do they have good turgor? Is their skin nice and tight, or is it weak and droopy? Those are all things that we can see and more from across the room. When at all possible, we want the parent or caregiver to hold the baby during the physical exam. This not only provides sensory comfort, but also makes our life easier because they're calmer. We do all of our painful procedures at the end of the assessment. So if you're going to take a BGL or do any other type of invasive procedure on an infant, wait till the end. That way you can get everything done before you have to make them upset. And of course, always explain what you're doing to the parent, to their caregiver, so that they stay in the loop. Because if they start getting nervous, the baby will get nervous. The next age we're going to look at is the toddler. The toddler is after infancy to 3 years of age. So 1 to 3 years old is when someone is called a toddler. They're usually growing pretty rapidly. There's a lot of changes going on. 12 to 18 months they start to become major explorers. At this point, they may be walking, they may be toddling around, they should be crawling. They're very adventurous by nature. They like to explore, and they're not afraid. Because of this, they'll climb up on things and fall off. They will go and explore things that might hurt them. They might poke the cat and get scratched. They might bug the dog enough that they get bit or scratched or something like that. If they're outside, they may ingest something. If they're inside and have gotten into a cabinet, they may try to eat things. One of the interesting things when it comes to these children is that younger children, especially infants and toddlers, don't have the nerve development in their hands and fingers that we do. You and I, like if I close my eyes and I pick up my cup of water, for instance, if my eyes are shut, I can feel this cup and tell you, okay, there's a lid here. It's got a lip on it. I can feel this cup and generate a mental picture of it in my mind just off of my hands. An infant or a toddler can't really do that. They have the most number of nerve endings in their mouth, which is one of the primary reasons that those children put everything in their mouth. It's how they interact with the world around them from a sensory standpoint. So this is why kids swallow things if they're putting it in their mouth. If it's small, a coin, a bead, a rock, it doesn't matter. They're going to put it up in their mouth, and if it's big enough or small enough, they can choke on it. They're also not able to fully chew their food, which also leads to an increased risk of aspiration and choking. From 18 to 24 months, these patients are going to be more clingy to their parents or a toy or something like that that brings them comfort. Try not to separate them from that unless you absolutely have to. When I work out on the ambulance, I carry 1 or 2 little tiny stuffed animals in my backpack with me so that if I deal with a pediatric patient, I can give that to them. And a lot of times it's enough to calm them down. Because of their clinginess and just separation anxiety, they're also going to have stranger anxiety. They're not going to like you, not personally, but because they don't know you. They're a stranger. At this point, they are learning that strangers are bad and that they're not people that are caring for them. So don't be offended if they don't want to talk to you or they're shy. They're going to resist separation from their caregiver, so when at all possible, try to keep them together. They're probably going to have a hard time describing any pain that they're in. Because of this, it can be difficult to assess when they're having abdominal pain or pain from a traumatic injury. Do the best you can, involve their caregiver, try to distract them from pain if possible. This will allow you to more thoroughly assess them without them being as distracted. That is how distraction can be bad for us, right? They can maybe not carry on the conversation. They might get distracted by a toy or a person walking into the area or a pet or something like that. We can also use that distraction to our benefit to divert, distract, and redirect them from something that's hurting. So those are all ways that you can distract them. Give them a toy, ask them about their favorite superhero, what their favorite movie is, what kind of shows do they watch, what do they like doing, do they like playing games, anything that you can do to take them off of whatever is giving you trouble in assessing them. We begin their exams at their feet and move upward. That is generally what you're going to do for both toddlers and the next one for preschool age. The preschool age is from 3 to 6 years old. They still have a higher risk of foreign body aspiration and airway obstruction. Their airways are still smaller, and we'll talk about that in another section. Preschool age children interact at a higher level, so generally they can understand simple directions, and they can be more specific when describing pain. They may be able to tell you more about their tummy pain or their arm pain or whatever the case might be. They still communicate fairly simply, however, which means that when we are communicating with them, we need to be simple and direct and not use big medical jargon. One of the things that you can use here is to appeal to their imagination. Like I said, ask them about their favorite characters. Ask them about what games they like to play. And never lie to the patient. Okay? We should never lie to any patient. but especially with children, if they catch you in any kind of deception, intentional or otherwise, will lose their trust. And once that trust is gone, it can be very difficult to get back. So involve parents where you need to, but don't lie to the patient. Distract them from something that you don't want to answer or can't answer, but don't lie to them about it. We're still going to begin the assessment at their feet and move to their head. Excuse me. And that Band-Aids are still a very good treatment for even minor things on these kids because it makes them feel better. You cover it up, it's out of sight, it's out of mind, it feels better. The last point I want to bring up with this is that their modesty is developing. So generally we want to keep these children as covered as possible because they're learning what that modesty and the privacy of their body means. And so they may resist you pulling up their shirt to look at their stomach or back. They may resist any other physical exams that you have. So involve their parents, involve their caregivers to let you help physically examine them if they're giving you problems. The school-age child is from 6 to 12. One of the big mental developments that happens here is that they begin to understand death. And as a child begins to understand death, even if they don't fully understand what that means or the implications of it, they know that you go away. They may have experienced it themselves in terms of a family member or a friend potentially, and they can be very afraid of it. They may ask you if they're going to die. Again, never lie to a patient. If they're actually grievously injured, maybe sidestep that or find an easier way to tell them that they're sick. I generally don't ever tell a patient, that, especially a child, that you're probably going to die. That's not good. But don't lie to them about that because they really are understanding. They're beginning to understand anyway what death means. Another side effect of this mental development is that their assessment begins to become more adult-like. It's still not an adult exam. You still can't treat them the same way. But you can speak more directly to them to gain their trust. Talk with that child, not just to the caregiver. They may be familiar with the process of a physical exam, so that may be easier for you. They may have had a sports physical before they went and played, soccer or something like that. So they may have a working knowledge of what you're trying to do. At this point, we are going to start at the head and move downward to the feet. Okay, this is where it changes. Before this, infants, toddlers, preschool age, we began at the feet and moved upward. For school-age children, we're going the opposite direction, starting at the head and moving downward. So, one of the things that you can utilize here to make your life easier is to give a child choices at this age. They can be very strong-headed and stubborn, and because they're afraid, they may tighten down and not want to do anything that you ask of them. One of the easiest ways and one of the first things that you can do to help alleviate this situation is give them a choice. But make sure that you're giving them choices and asking questions that let you control what's going on. Don't give them the option of, well, do you want to go to the hospital or not? If they need to go, or if a parent is telling you that they want them transported, they have to go. But if they're not willing to do that, start giving them little options like, well, would you like to walk outside with me to the ambulance, or do you want to get on to my bed? That gives them choice. That gives them a little bit of freedom back and a little bit of control, but you're actually maintaining the control because both options result in them getting into your ambulance and being transported. Do you want to take your blue blanket or your stuffed animal? Okay, again, it's not are you going or are you not going? It's we're going, but you get to make a decision about how you go. Other things that you can do to help allay their fears, involve them in the assessment. Let them listen to their heartbeat. If you're working on an ALS unit, maybe hook them up to the cardiac monitor and let them see their heart. Kids that I've encountered have generally really enjoyed that. It's another form of distraction that can maybe get them into a better frame of mind. You need to understand because they are starting to understand the difference between physical and emotional pain. Understand the difference between somebody who is hurting because they're sad versus because of an injury. And if you're careful, you can actually just see this in them a lot in the way that their body language is displayed. We still need to provide explanations about what's going on, not only to the caregiver, but now to the patient. But be simple with it. Don't use big medical words or jargon. Tell them that I'm going to check how sweet your blood is or how much sugar you have in your blood. Instead of saying, I'm going to check your blood glucose level. Okay? Use different phrases, something that they will understand a little bit more. Ask their parent or caregiver the best way to go about checking with them or assessing them, because they will know how their child behaves and how they interact and might be able to give you some pointers to calm them or otherwise gain their trust in a little bit faster. The last stage that we're going to look at is the adolescent. The adolescent is defined as 13 to 18 years old. At this point, physically, they're very similar to adults. There's still changes that are going on, but structures like their airway and head are a little bit more proportional to their size and a lot closer to their final adult size than younger children are. Emotionally, they're still children. I hope none of you take that personally. But the maturation process in terms of emotion and the way that you're processing the world around you is not yet completely mature. Now, I would argue there are plenty of adults that don't have a mature way of expressing their emotions. So you kind of got to take that in stride a little bit. This is also a period of increased risk-taking and experimentation. So the number one cause of death of all pediatrics, but especially in this age range, is trauma. So that can result from kids doing stupid things, jumping off roofs, climbing up things and jumping off, trying to make YouTube videos, whatever the case might be. Tide Pods. Need I say more? Assessment of these patients is a lot more like the adult assessment in that they can understand more complex concepts. They can understand treatment options. They probably have some level of working knowledge of science and biology and medicine potentially, allowing them to more easily communicate with you and understand what's going on. Involve them in their care. Let them know what's going on. Give them as much control as you can, because they're going to know when you're presenting a load of crap. And again, you don't want to lie to them. Involve them in that care and make sure that they know what's going on. However, they can still be fairly uncomfortable. Allow an EMT of the same gender to do the physical exam if at all possible. There's still a lot of modesty issue that can go on here. So you want to make sure that you are doing this in as comfortable an environment as possible. Allow them to ask you questions and be open about those answers. Again, don't ever lie to a patient. This is also the range that we need to start thinking about female patients being pregnant. Know that that is an option, depending on whether or not they have had their menarche and their menses have begun. That's not necessarily something that you need to assess on every single patient, but it is something that should be in your differential if the signs and symptoms allow it. So over all of childhood, their body is growing rapidly. It's changing very quickly, and this can cause not only its own set of pains and growing pains, but it can also cause fear and embarrassment. As that happens, you need to be cognizant of it and treat them with respect. We do need to understand the physical differences that present themselves between pediatrics and adults, and we're going to kind of look at some of the major areas where that is different. The first is let me see if I can pull this up here. The first that, arguably biggest, is the pediatric airway. What I want you to see is that between this area where I'm drawing this line, here right by the epiglottis, especially, let's say over here as well, on an adult it's fairly large. On a child, it's smaller. Okay, so right up here behind their tongue is their airway, proportionally much larger on an adult. The other thing I want you to pay close attention to is that proportionally for the size of their mouth, their tongue is much larger. On an adult, there's a lot more room in their mouth and oropharynx for this tongue, not so much on a child. And so the number one airway obstruction is still the tongue, but as you can see, this airway is smaller in diameter. Their lungs are smaller. They can't hold as much air. Their airway structures are not developed. Their intercostal muscles are not developed. Their heart and lungs sit higher up in their chest. We think about that's why for CPR, especially on infants, we are actually up a little bit higher on their chest than on an adult. On an adult, that heart is sitting down here, okay, right at the nipple line. On a child, it's a little bit further up. So that is the first place that we need to look at, and this actually impacts a lot of our treatment that we do for them. The glottic opening. So the glottic opening is higher up in their airway. It is anterior, more anterior anyway, and on younger children, they may not even have much of a neck present. It may seem like they go straight from head to shoulders. Their neck is there, obviously, but it's a lot smaller. And so maintaining that airway becomes more problematic. As they develop and get older, their vocal cords and their epiglottis move into what we consider more of a correct adult anatomical position. Their head, proportionally, is much larger than the rest of their body. If you think back to the rule of nines when we talked about burns, you remember that the proportion, the percentage of body surface area for a child is bigger than an adult when it comes to their head. This means that their airway is more easily occluded by their neck because their head is going to be hanging back, pushing up like this. If an adult lays flat, their neck and their head are probably going to be in pretty much a straight line, assuming that they're not massive. But when a child lays down, because their head is so much bigger, because their occiput is bigger, it pushes their head down like this. And that means when you're bagging them using a BVM or otherwise trying to maintain their airway, you may need to pad underneath their shoulders to bring them more into a flat line anatomical position in their neck to their chest. Their epiglottis is long and floppy. If this gets inflamed and infected, it's something called epiglottitis, which we'll talk about. And that can cause a major airway obstruction if that suddenly swells up. Their cartilage rings in their trachea are less developed. They're softer. And because of that, if you hyperextend their neck, if you bend their neck back too far, they will actually push up, their spine will actually push up from the rear and close off their trachea, or at least make it much smaller. That can make your airway management difficult. The other thing I want to draw out is that an infant, their trachea, is about the size of this drinking straw. Okay, this is about a centimeter across, if that. That's pretty tiny. That's really tiny. And that can be blocked by so much, right? A little piece of ice can get into your straw and block it. I mean, think about even just like if you're drinking a lemonade from Chick-fil-A, sometimes you'll have some of the pulp get into the straw, and that can severely restrict the amount of lemonade enjoyment that you're going to get until you clear that. Imagine if that was an infant's airway, okay? Really, really tiny things. A child has an oxygen demand that is twice that of an adult. Yes, you read that right. Twice that of an adult. They breathe faster because their lungs are smaller and they need more oxygen. Their diaphragm dictates the amount of oxygen that they inspire. Their chest muscles are not as developed, so their diaphragm in particular is what controls the depth of their breathing. Because of that, anytime gastric distension is present, be it from an injury, be it from an infection or a malformation, a congenital abnormality, anything like that, anytime you have gastric distension, that will impair their ability to breathe, because the bigger their abdomen is, the less room there is for their diaphragm to move. The other time this is an issue is if you're bagging a patient and you're not doing it appropriately and you're pushing air into their stomach. As their stomach inflates, they get the gastric distension and their lungs can't expand as much. Their chest walls are much thinner, so breath sounds are pretty easy to hear on these patients because of that. The downside is everything is smaller, and because it's easier to hear, you will have a harder time differentiating what part of their lungs are being inflated. Sorry, Zoe was looking the floor down here, and it was quite distracting. So anyway, we were talking about gastric distension in terms of their diaphragm and being able to move. We talked about that, and then we talked about how air movement can be difficult to hear in specific areas because their chest wall is thinner. Vital sign ranges on children are different than that of adults. You need to know these, and there's going to be a table in your book that will show you the normal vital sign ranges for children. For starters, an infant's heart rate can be as high as 160 beats per minute, and that's perfectly normal. If you or I have a heart rate of 160, we're either exercising or we're having a major cardiac problem because our heart should not be going that fast, but an infant's should. Children are usually unable to compensate as long as an adult, but they can compensate fairly well. Their initial compensation is by shunting blood away from their skin. So they constrict the blood vessels at the surface level of their skin and pull that blood back to the core. Because of that, some of the first signs of shock that you'll see are skin signs. They may have pallor, they may be gray, pale. They may just look sick. You're going to see weak distal pulses in the extremities, okay? If you're feeling for a radial pulse on an older pediatric patient or a brachial pulse on a younger one, if those are weak, or if you see cool hands and feet, those are signs of peripheral shunting. Those blood vessels are constricting and trying to push blood back towards the core. So here's a pulse rate chart. We know that newborns can range anywhere from 85 to 205 beats per minute. All the way up to anybody over the age of 10, their heart rate is actually more normal, what we would consider normal for an adult. Know that their lower end heart rate, as you can see up here, can be the same. So between 2 and 10 years old, their minimum heart rate, acceptable heart rate is 60, but their upper level is a little bit higher for the younger kids. As you get older, everything should start to slow down and become more normal. All right, so we talked about the size of the occiput in terms of airway management and how that can create an obstruction, but this also leads to children falling and leading with their head. So you will see more head injuries in smaller children when they fall because their head hits the ground first before the rest of them does. Their head to body ratio is disproportionately large for the infant and the young child. Their nervous system is immature, it is underdeveloped, and it is not as well protected as for an adult. The subarachnoid space, okay, it is relatively smaller than an adult's. There is less cushioning there, and so even a small bleed can cause a problem. Their vasculature and their brain tissue itself is less developed. It is more brittle, and so shearing forces can cause bleeding in the brain, and they can't compensate as well as an adult can for that. They're also more sensitive to changes in oxygen and blood flow, kind of go hand in hand, and glucose. So a diabetic child may have a brain injury quicker because of that. A hypoxic event, be it from an illness or an injury or an overdose, is more likely to lead to a secondary brain injury faster. It doesn't let me go back while I'm recording, but the spinal cord itself is also more prone to injury as well. Those structures and those bones are not quite as calcified. They're softer, so they can have injury. The cord itself is generally okay, but the bones around it and the structures around it may have more trauma than you would see correspondingly for an adult with the same mechanism. The abdominal muscles are also less developed. Next time that you look at a toddler, you'll notice that poochy belly. It's not just because they have baby fat on, but it's also because their abdominal muscles can't hold their innards in as well. Those muscles are still developing. They're less protected from trauma because of that. And their liver, spleen, and kidneys are proportionally larger than the rest of their organs. They take up a much larger fraction of space in their abdominal cavity than it does on us, and so they are more prone to injury and bleeding because of that. kids are also growing. Their musculoskeletal system is developing. Excuse me. Because of that, they have open growth plates. If a child is injured orthopedically on a growth plate, that can stunt the growth in that area, and they may have to have surgical intervention to fix that problem. So bone breaks that happen, fractures that happen over the growth plates, which are usually on the upper ends or lower ends of a bone, can cause lifelong problems, whereas on an adult, those growth plates are closed and it's just another bone fracture. So bone length discrepancies can occur because of that. Bones of an infant's head in particular are flexible and soft. They have something called a fontanelle up here on the top of their head. There's a couple of them, but they're all generally up top. That is a soft area of their skull. It's a great way to assess whether or not they're dehydrated, because they should be, soft but equal with the rest of their head. If they're depressed or bulging, that's abnormal. Especially if they're depressed, that generally means that an infant is very dehydrated. The last thing there's one more slide, but one of the last things we're going to look at on this page is that their thoracic cage is much more elastic and pliable. So they can absorb a lot more energy, a lot more traumatic energy without breaking a bone. So just because they don't have a bone break doesn't mean that there's not internal injuries underneath. Even though their bones didn't break from the energy, they may have shearing forces on the inside and internal bleeding going on because of that. All right. So there you go. That is the end of section 1. And we've got a few more of these to go. I'll see you on the next slide.